Welcome to AFMC TV. I'm Robin Ledbetter.
The goal of that is to maximize people's quality of life, right?
You want to make sure that your housing is affordable in your community.
We have to think about vaccines in a way that we haven't thought about them before.
I had a lot of the legislative adults who were very creative.
Down on the floor and play with their kids.
AFMC TV. Thanks for watching and have a great day. Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Tim Goodson. He's a board-certified urologist at Arkansas Urology. Dr. Goodson, thanks so much for being here.
It is a pleasure. I appreciate the invitation.
So can you start by giving us an overview of what the PSA test is and why it's used in prostate cancer screening?
Sure. A little bit of history. Prior to the PSA testing, we didn't have a good way to screen for prostate cancer. And most prostate cancer cases were found in advanced stages. I mean, it was really, not a good situation. So PSA screening, although it has its flaws and concerns, has saved a lot of lives over probably the last maybe 3 decades, something like that, maybe a little bit longer than that. But PSA, it's an antigen or a chemical, if you will, biological chemical that is produced by the prostate gland, and it's not produced in anything else. It's always a prostate cell that produces that antigen. So it lends itself to evaluating, what's going on in the prostate gland. Now, PSA is short for prostate specific antigen. You get that word out. It is not cancer specific, which is why the interpretation of that value is maybe a bit more complicated. In other words, a high PSA, as an example, does not mean someone has prostate cancer. It may make them suspicious, and recommendations come from a high PSA, for further evaluation. But for years, we've screened men for prostate cancer. The original value that was assigned to be, either normal or abnormal was under 4 and over 4. And as time has gone on, that has been tweaked a number of different ways, and by different, healthcare organizations. The current American Urologic Association, as well as the American Cancer Society recommendations, do cutoffs at below 2.5 being normal, above 2.5 to 4 being abnormal, or at least in consideration for further investigation, and then above 4 a pretty hard recommendation for further investigation to perhaps include a biopsy.
And who should be screened? Like, what age demographic? When should that begin? Right.
Well, and that's another great question. From the decade from 40 to 50, it's really exclusively certain categories of men, African American men, who are at higher risk of prostate cancer, not only having prostate cancer, but also they tend to have higher grades of prostate cancer and more concerning disease. And so African American men should certainly be screened starting at age 40. Someone who has a known genetic predisposition, either through genetic testing, for instance, the BRCA 1 and 2 genes put someone at a higher risk for prostate cancer. For those who aren't familiar with that term, those are kind of breast cancer genes that increase suspicion of a familial concern about prostate cancer in a particular family. Just a first degree relative, father, son, brother, any first degree relative that has prostate cancer should be screened earlier at age 40. And then one other interesting thing is, men who the women in their family have a predisposition for breast cancer should also be, or at least consider earlier screening than those without those kind of 4 or 5 factors that I just outlined.
And how have these recommendations changed over the past few years?
Well, to be honest with you, we've taken a tool and probably applied it indiscriminately early on, and collectively the medical community and certainly urologists and cancer specialists have expressed concern about the overdiagnosis of prostate cancer. And then which leads to overtreatment, right? And so, and I can't tell you the year, but say 12 to 13 years ago, the NIH had a task force that came out and just kind of was very negative about prostate cancer screening, and just basically thought it all should all be abandoned. Well, they kind of threw the baby out with the bathwater, and a couple of years later they walked that back, and so now we try to be more judicious. But the reason that that's a concern is that prostate cancer, just for simplicity's sake, comes in a couple of different varieties. One that is low grade has very low risk of metastasis, which is where prostate cancer really starts, hurting a man, and somewhat indolent. In other words, men can have a low grade prostate cancer and not have a lot of risk from that over time. And we've actively in my career, we've gone from kind of wanting to treat everyone early on in my career, certainly last probably 15 to 20 years. Most of us, all the, if I can say up-to-date urologists, have a lot of men on what's called active surveillance. And that's a man who has a low-grade prostate cancer that we deem the risk is low enough that we can follow that cancer. Somewhat analogous to someone who has polyps in the colon, and they don't need their colon out, but they need to be screened more frequently with colonoscopy. And so a low-grade prostate cancer, although still cancer, and there's still some risk there, excuse me, most of those men are under active surveillance. And then the other category of prostate cancer are the ones the cancers that look very much like a more aggressive type of cancer that metastasize, grow cells or tumors in lymph nodes, bone, even lung, although rarely. And so those cancers are the ones we want to find. We want to, screen men in such a way that we find more of those cancers and fewer of the lower grade cancers, which cause anxiety, further follow up, and that sort of thing. But it's a challenge. But I think the urologic community as a whole and most providers understand that now.
And can you explain the role of repeat PSA testing, free versus total PSA, or other adjunctive tests like MRI or biomarker panels? You did mention the biomarkers.
Yeah, there are several different panels that can be used. And so the situation is that when you have someone with an elevated PSA, perhaps you do the workup, either MRI, possibly biopsy, and you determine that they're at low risk, but they probably will still have an elevated PSA. And so you're kind of left, and that PSA will likely go up. And so you're left with a situation that, 2 years down the road, 3 years down the road, you got a situation, maybe a gentleman had a slightly elevated PSA. Well, that PSA is increased. And so, what are you going to do in those situations? And if the gentleman had a PSA, elevated PSA with a subsequent biopsy, and then 2 years later, you've got a higher PSA, well, you haven't completely ruled out cancer. You did, you ruled it out the day that he had the biopsy, but you got a decision point to make. formerly we didn't have as many tools, and we really just had another biopsy is the next thing to do. Now MRI is proving to be a very good tool. It came on the scene probably maybe 8 to 10 years ago initially. Has gotten much more mainstream where we're routinely getting MRIs on many people with elevated PSA before a biopsy, or for those that have had a biopsy as a way to follow up with that patient. And the MRI does something that PSA and some of the other markers don't do, and that is it identifies more precisely and more specifically men who have a greater risk of having intermediate and higher grade disease. And if someone has an MRI with a positive finding, in other words, there's an area that is concerning for prostate cancer, that can be marked by the radiologist digitally in 3 dimensions. And that information, that digital information, can be overlaid or fused, is the word we use, with an ultrasound image, so you can come back in and you can do targeted biopsies of that specific lesion, which makes the biopsy much more accurate, and it further is a way to kind of target diagnosis. And of course, we also have many more targeted therapies than we used to.
And what do you see as the biggest challenges for providers that they face in managing patients after an abnormal PSA?
Well, just, there's this concept that we call shared decision making. And since there still persists some controversy is probably not the right word, but concern over too many biopsies, too many treatments, then you kind of bring the patient in along, by your side, and they can, they have this shared decision-making process. Well, how concerned are they? For instance, as you mentioned, a guy that had maybe a previous biopsy, and 4 or 5 years later, his PSA has gone up 2 or 3 points, and the concern is raised again. And in that situation, most of the time, at least in my practice, we would do an MRI. And then if that shows an area, then the recommendation would be to do a biopsy. But if you do an MRI and it's completely negative, there's no signs of concern, then you may forego biopsy. Certainly for that year, or maybe the next year, and just follow that patient over time with PSA, as well as, and I haven't mentioned this yet, digital rectal examination. That's certainly an adjunct to PSA screening that is important. Because when we, on digital rectal examination, the urologist or a family practice or general medicine doctor feels the backside of the prostate gland digitally. And if there's a hard knot back there, then that puts them on a whole different risk category than someone who has a nice, smooth prostate gland on DRE.
And can you walk us through the main treatment options, the surgery, radiation, and hormonal therapy? How do you decide which approach is best?
Sure. So, the mainstays of prostate cancer therapy are those that you've just mentioned. Radiation is used for, locally confined prostate cancer that where someone, quite frankly, does not want to have an operation, which is a valid concern and perspective. And radiation versus surgery, those can both be applied for local disease. And we walk through, again, this is that shared decision-making concept where we walk through the pros and cons of each of those approaches. What the holy grail of any treatment would be 100% success with 0 side effects, which doesn't exist in the real world. And so there's this balancing act of what the patient wants to go through, what risk he's willing to take. And I have patients who have different biases on that topic. I have patients that would avoid surgery at all costs if any option is available. I have others that see surgery in a better light, and they're happy to go through that because they feel like they've gotten a better, more complete treatment. Radiation and surgery by themselves, without any hormone therapy for lower grades of prostate cancer, the success rate in terms of no recurrent disease over time is roughly equal, which is another reason why we kind of do this shared decision making and try to inform the patient of the pros and cons of each of those approaches. And of course, the side effects of treatment are very personal to a man. They can be bladder control issues, erectile dysfunction issues. And so obviously, these are things that the informed consent goes in great detail, because the concern about those two areas of a man's life, again, very personal and can be long-lived. We are doing better on both of those fronts, thankfully. The advent of the robotic prostatectomy has enabled the robotically trained urologic surgeon to be very precise and be able to spare the nerves. When we use that term, sparing the nerves, it just means the nerves and the vessels that enable a man to have an erection can be swept off without a great effect in terms of cancer control, but sparing the erections. It's not a perfect world, but it's certainly, so much better than, as an example, maybe 2 decades ago, where virtually everyone who had their prostate gland removed had some level, if not total, erectile dysfunction.
Where can healthcare providers go for additional education and resources? Where do you recommend they start?
Well, American Cancer Society has a plethora. Their website has a plethora of information. It's one of the tools I use for education with my practice. Memorial Sloan Kettering, same thing. Those 2 sites are excellent, and they certainly are up to date, and they're very even-handed and judicial in the information provided. I teasingly tell my new diagnosed prostate cancer patients, please don't Google prostate cancer. We've all been on the internet, and there's good information and perhaps not so good, or information that is somewhat biased for whatever reason. But there are good sites out there. I'm brag on us a little bit. Arkansas Urology, first one to do PSMA PET scans that show us exactly where the tissue is. First ones in Central Arkansas to bring Pluvicto as that targeted therapy I was just mentioning. There's just a lot going on now, and we certainly don't have those technologies exclusively, but we spend a lot of time and effort and expense to make sure that the folks in Central Arkansas and really around the state, because we see people from really most corners of the state, for them to have up-to-date, user-friendly, caring patient care. And I think largely, we're successful in that. And so this is not something where Arkansas ranks low on the national totem pole. We rank, right there with the best of the best. Across multiple institutions, ours being one of them.
That's good news in that regard, for sure.
Yeah.
Well, Dr. Goodson, thank you so much for sharing your expertise and information about this important topic. I appreciate you being here today.
You are most welcome, and thank you for having me.
And that's it for this episode of AFMC TV. Have a great day, and thanks for watching.